Top Bed Talk.
Between myself and Dr. Coary, we're going to speak today about perioperative management of patients with a vulnerable brain. So that will include patients such as the elderly, those with cognitive impairment, and obviously critical care patients. But fortunately, the session we have is probably not quite long enough to include those with us today. I am currently working in the Royal London Hospital, and I'd like to thank the Peri-operative Medicine Society for having me here today. I'll talk specifically about the immediate perioperative care and intraoperative care of patients, and Dr. Coary will talk more about the pre- and post-operative care. So as adult anaesthetists, the most vulnerable patients we care for would be those who are elderly, those who are critically ill, and those with cognitive impairment, as I mentioned. And that there are many things that can affect cognitive impairment. Surgery is one of them. It can manifest as either post-operative delirium in the hours post-operatively or post-operative cognitive dysfunction, which tends to occur more in days and weeks post-op. Those with preoperative cognitive impairment are much more likely to develop post-operative cognitive impairment or deterioration in their cognitive impairment. And it's quite a large proportion of our patients that have undiagnosed mild cognitive impairment. In fact, it's estimated that 20% of hip fracture patients and up to 50% of those undergoing emergency general surgery have problems with cognitive impairment pre-op. As the elderly population increases worldwide, as do the proportion of patients who are elderly who undergo surgery, there are a number of procedures that may be carried out in order to improve things that may contribute to cognitive impairment. So if you alleviate pain in patients who have cognitive impairment, you may in fact improve their cognitive impairment by doing that. If it improves pain, if it improves mobility, hearing, sight, these may all benefit the cognitive impairment in the patient. However, surgery is a multifactorial insult to the brain, and there are many factors that occur in the perioperative period that can contribute to cognitive decline. As I mentioned, post-operative delirium is common. It occurs in 10 to 60% of our patients, and post-operative cognitive dysfunction in 15 to 30. There has been an effort made to try and separate out the insult of anesthesia from the insult of surgery. This has demonstrated that in those without previous cognitive impairment, actually there is no delay in recovery in any patients between ages of 40, ages of 50, divided out into kind of brackets of 10 years, so 40 to 49, 50 to 59. The Baxter et al. In February just of this year didn't actually display any worsening in cognition or delay in recovery after exposing patients to anesthesia alone. However, it is rare that we expose patients to anesthesia alone ethically. Therefore, I'm not sure that this unties the complex process that occurs to patients during their perioperative journey. Unfortunately, from an anaesthetic perspective, there isn't any clear mode of anaesthesia that benefits the patient. Studies done at Cochrane Review meta-analysis in 2018 had a look at TIVA, both TCI and non-TCI, and inhalational anaesthesia, and unfortunately there were no differences in post-operative delirium and cognitive dysfunction seen in 28 RCTs and 4,500 patients. Another meta-analysis in 2011 also showed no difference in cognitive dysfunction between patients receiving general anaesthetic and those receiving regional anaesthetic. What can we do for our patients when they arrive in the anaesthetic room or in the theatre in that immediate perioperative period? So, unfamiliar environments are not very nice environments for patients with any kind of cognitive impairment. If you can orientate them, familiarise them with the environment, make it quiet, make it friendly, this allows for the patient to be relaxed. It makes them less confused. If they can be accompanied by a carer during this time, it can be much more pleasant for the patient. They have somebody who understands their needs. There's an excellent document that we can see on the right-hand side of the slide here, just in the corner, called This Is Me, and this has been produced by the Alzheimer's Society. It's an aid which can be transferred from carer to carer, which illustrates particular needs that patient may have, the patient-specific requirements, what calms them down, what name they go by, which seems very basic, but not everybody goes by their first name, and if they require any hearing and visual aids, because these are going to be very useful for the patient to remain in place until induction and to be put back in place after emergence. Simple things such as to orient the patient, such as clocks, so they know what time it is, telling them what day it is when they wake up, making sure that they know that they're aware that they're in hospital. Although having a patient with cognitive impairment as a day case seems counterintuitive, in fact, maintaining these patients in their own environment for as long as possible and returning them to that environment as soon as possible can be very beneficial. Recommendations for anaesthesia then. As I mentioned, there isn't a specific kind of anaesthesia, unfortunately, that demonstrates benefit over another. However, there are some kind of basic common sense approaches that we can consider when talking about anaesthetic process. It's important to avoid medications which are going to increase cognitive impairment, such as benzodiazepines, steroids. Opioid-sparing techniques can be very useful as they reduce confusion, sedation, and constipation. And avoiding those medications which have a central anticholinergic effect, such as atropine and first-generation antihistamines. Considering the use of antiemetics, it may be more useful to use Tiva due to the reduced incidence of postoperative nausea and vomiting. Another thing to bear in mind in these patients is medications such as donepezil, which is a cholinesterase inhibitor, can interact with neuromuscular blockers, so it's important to keep that in mind. Obviously, as with all good anaesthetic, it is very important to maintain physiological homeostasis, which will reduce postoperative complications. From the point of view of the evidence, there's been a number of studies, and I will just highlight a few. Back in 2013, Chan et al. Had a look at BIS monitoring in these patients. Actually, both groups received BIS, but in one group, the BIS was hidden, therefore the clinician was unaware of the score. In BIS versus routine care, there was a reduction in the incidence of delirium from 24.1% to 15.6%, and a lower rate of postoperative cognitive dysfunction at 3 months in these patients as well. A very similar study was repeated then this year, published in 2022. And again, BIS was taken in both patients, however, it was hidden in the routine care group. This group with the hidden BIS had much more time at a BIS score of less than 40, and they demonstrated a statistically significant reduction in postoperative delirium in the visible BIS group, and also an associated reduction in hospital stay and mortality. Then Everett et al. In 2021 looked at slightly sicker patients, ASA 3 and 4, and looked at light versus deep anaesthesia, and there was a reduction in postoperative delirium from 28 to 19% in the visible BIS group, or in the elevated BIS group. However, they were all within the normal parameters of 40 to 60. Finally then, a Cochrane database systematic review in 2018 compiled of 6 trials with greater than 2,000 patients, and they concluded that there is a moderate quality evidence that processed EEG reduces the incidence of postoperative delirium. So, depth of anaesthesia monitoring is obviously processed EEG, and EEG has been in existence for quite a while. In its infancy, in 1937, EEG work was predicted to be available in a continuous manner as EEG recording by Gibbs, and Lennox, who were involved in the original composition of EEG. Obviously, the format of EEG that we use is processed, and most common types available are BIS, entropy, and narcotrend. BIS and entropy both use a similar index number, and you target between 40 and 60 for your anaesthetic depth. However, entropy has both 2 figures, resting entropy, and that gives us information. The scale is from 0 to 100 and includes frontal EMG and has a fast reaction time as it detects facial muscle activity. However, state entropy is 0 to 91 and excludes EMG calculation. So, bispectral index I'll focus on today as it is the most commonly used and for which there is the most evidence. It was introduced in 1996. Unfortunately, the companies are not keen to release the proprietary algorithm. So from our point of view, it is a dimensionless number that is calculated by the originally Covidian, and now there's a number of different companies. There is the index number, which I spoke about, which we tend to target. There is, unfortunately, a fear of accidental general awareness under general anaesthesia when using this monitor, and I'll speak a little bit more about this. But it's important when you're using the BIS as a depth of anaesthesia monitor to avoid using the index number in isolation. There are many other elements outside of the index number which are produced by the monitor and can be used to determine depth of anaesthesia. And the purpose of my talk is to basically to urge everyone to move away from using solely the index number. So the evidence when it comes to accidental awareness under general anaesthesia, if you're somebody that is worried about this, I can assure you that when BIS is being used in a more comprehensive manner, actually it can be very useful in determining. Unfortunately, accidental awareness under general anaesthesia is actually quite rare, and for that reason, very large numbers are required to assess its presence in various populations. As we saw from NAP5 in 2014, the incidence is 1 in 19,000 1,000 at best and 1 in 6,000 at worst. It's more commonly seen in TIVA. This is more commonly seen in TIVA, and there was an increase in accidental awareness in TIVA in NAP5 seen, but it was deemed that this was as a result of kind of unawareness with technique, and actually only 23% of people used depth of anesthesia monitoring in these patients. Then there are a couple of Cochrane reviews looking at the benefit of using this as a depth of anesthesia monitor and preventing awareness. In summary, if you are using it instead of monitoring clinical signs, there is a benefit, and it does reduce the incidence of accidental awareness under general anesthesia. However, it is comparable with end-tidal gas concentration. So that is basically the conclusion of both the Cochrane systematic review and the meta-analysis that we see there. So just speaking a little bit more about electroencephalography. So it is a measure of the electrical potential between two areas of the brain. In order to adequately interpret this monitor, having a little bit of background of electroencephalography is very useful. On the top right, we see the component frequencies from which brainwaves are composed, and they extend from slow, which is 1 hertz per minute, as up to gamma, which is 25 to 80 hertz per minute. The amplitude may vary of each frequency, and as the amplitude increases, so does the power of that particular frequency, and that's important to remember when we look at a spectral array. So if we examine states of sedation and anesthesia, we can see that as the depth of anesthesia increases, the frequency of the EEG decreases. When awake, we have high frequency, low amplitude beta, which is generally 12 to 25, and gamma, 25 to 80 hertz per minute. As we approach sedation, oscillations occur between beta and alpha, and there's some increase in amplitude in compared to awake. Then, as you become more sedated, prominent slow delta comes in, and the lower frequencies but higher amplitudes are seen. As depth then increases, your amplitude reduces until you can get to periods of suppression, which is undesirable. Burst suppression can then progress to isoelectric, and then at this point we are in an anesthesia-induced coma. That pattern may also be seen in severe brain injury and hypothermia. So there are a number, unfortunately, of caveats when it comes to interpreting the BIS number in isolation. As we know, not all anesthetic agents or sedative agents affect BIS in the same way. Ketamine, because it increases beta and gamma activity, can cause an elevation in the number. Neuromuscular blockade has been found to, due to its abolition of electrical myogram, obviously reduces our BIS number. However, it can be found to be artificially low even in patients who are awake. Therefore, higher vigilance and greater interpretation outside of the index number is required in the setting of neuromuscular blockade. Other things to bear in mind that can reduce conscious state but don't affect BIS are opioids. And here's just some brief studies that look a little bit more closely at those effects. If you look beyond the index number again and examine your spectrogram and your EEG, you are less likely to misinterpret the index number. So I'll just go quickly through how the spectrogram is produced and how we can identify different anesthetic agents. So the initial waveform, as we can see in the top left corner, is composed of both alpha and slow waves, and this is split into different frequencies. On the spectrogram, we get obviously an elevation in those particular regions. That corresponds with a high power on our 3D spectrogram. The 3D spectrogram is then placed on a 2D spectrogram, and the higher power is indicated by a red number and the lower power indicated by blue. Then when it comes to our screen, we see on the left-hand side is the index number. Just above is our signal quality index. This is very important when you have interference from extra cut. The signal quality will reduce and it will indicate that there is some interference. This can also be indicated in the presence of poor electrode contact. Your suppression ratio can indicate if there is an element of burst suppression and is averaged over the previous minute or 63 seconds. Then your EMG activity is indicated by the bar just next to your index number. Here we see different spectrograms produced by various anesthetic agents. So propofol, we can see, has a high power in delta, close to the bottom, and the red line just above that is alpha, and that's a very common trace for propofol under an anesthetic state. Sevoflurane has a high power at both alpha, theta, and delta. In sub-MAC concentrations, it's possible for SIVO to appear more similar to propofol. Ketamine then, as an NMDA receptor blocker, causes oscillations in beta and gamma, and you can get an increase. You can see the yellow there in the slightly higher frequencies. Then with dexmedetomidine, the EEG pattern is actually similar to slow wave sleep, and you can have delta oscillations and spindles, which is what you see just above the red and the green there, between 9 and 15 hertz. As you increase your concentration, then those spindles will reduce. Another thing to bear in mind is the fact that anesthesia can actually change as age goes on. You tend to have a lower power in older patients. So even though these are the appropriate spectrograms for patients of various ages, we can see that the power is less with increasing age. And lastly then, a kind of scenario that we wish to avoid, especially in the older patient, is the presence of burst suppression. So increasing depth increases the burst suppression ratio, and that is the greater amount of time that the patient has a suppressed trace, and this is inversely proportional to your BIS number. So it is important to consider at this time your depth of anesthesia, but also other potential causes for burst suppression, such as seizures, hypoglycemia, hypothermia, or other intracranial events. In summary then, it is important to consider the patient's perioperative journey when we want to minimize cognitive impairment. Ensure that there is preoperative assessment to identify cognitive impairment, optimize the perioperative environment. There is no anesthesia technique that is best, so the one that you are most familiar with is best. Definitely look outside the index number when using depth of anesthesia monitoring, and always consider the post-op disposition of the patient.
Dr. MacDarby for that stimulating discussion on particularly BIS monitoring. Our next speaker will be Dr. Roisin Coary. She is a consultant geriatrician in Connolly Hospital, Blanchardstown in Dublin, and she has a special interest in peri-operative medicine. She undertook a fellowship with Richard Stevens Bursary in perioperative care of the older person, and we look forward to hearing her talk under the theme of protecting the vulnerable brain. Thank you.
Hi, how are you? Hope you can all hear me. I'm presenting from home today, and I just wanted to say thank you very much for the opportunity. I'm a geriatrician, and I'm coming at this, I suppose, from a different viewpoint. And I really just wanted to follow on from Dr. MacDarby's talk. I think the more you go into it, the more complicated it gets. And I don't think there's going to be a simple solution or a simple fix to any of this. It's not going to come down to what type of anaesthetic, kind of regional versus general. It's going to be about kind of probably a whole systems approach to managing this. And it's going to be a lot of kind of small, minor changes in trying to optimize patients coming through the perioperative process. And what I want you to think about is just your own setup where you are in terms of, elective versus emergency surgery. In terms of your pre-op assessment, are you looking for cognitive impairment? Are you aware of any delirium or dementia pathways that are already in the hospital? And is there anybody taking responsibility for this? You're coming at it kind of from an MDT perspective. And really, I think this is where the money is going to be. Where I tend to get involved as a geriatrician is at the end point on the ward. And kind of worst case scenario, you're called to see a patient who's been in for probably days or weeks. Even, a few weeks ago, I had a surgical colleague of mine asked me to come and see a patient who was come in for an elective procedure, got a delirium, and they couldn't get her out of hospital. And I'll not forget the words she said. She had her pre-op assessed, and she said, they told me she was fine. Then, this outcome happened. And this is typically where we get involved. And it's trying to prevent this sort of thing from happening is really the ultimate goal. I think Dr. MacDarby has already alluded to this. And really this slide is just to say people are getting older, and the vast majority of people who are having surgery are older. And I think looking after older patients has to now be the standard of care. You have to be familiar with looking after older patients and all of that, that entails. The number of people aged over 85 is going to quadruple in the next 30 years. So really that's what we're looking at. And that's what, as geriatricians, we would like to see is just that managing older people should become standard of care. As you get older, there are higher rates of cognitive impairment, specifically dementia. So you're going to be looking after more people who have a dementia. But be aware about a third of all cases of dementia are undiagnosed. So there are going to be people that you're seeing, say, preoperatively, who won't know they have a dementia. And if you ask them, they may not even be aware of it. And you'll only pick it up if you actually look for it or start screening them. And really, it is prevalent. So these are just a few studies to show how prevalent. These are well patients going in for elective surgery, estimated kind of cognitive impairment of nearly half of older patients, and it'll probably be higher again in certain cohorts, such as vascular patients. If you do have an underlying cognitive impairment in the form of dementia, you're really likely to get a post-op delirium, and that is bad in terms of complications, length of stay, mortality. Even looking at elective orthopedic patients, almost a quarter might have a pre-existing cognitive impairment. And then post-operatively, again, delirium is really common. It's probably more common than you even think, and especially if you go looking for it. About a third of abdominal surgery patients, emergency abdominal surgery, about a half of all hip fracture patients, and even Dr. MacDarby was quoting, I think, some of the BIS papers from 2013, like when they actually looked for delirium, it was, I think, between 24 and 28%. So that's like 1 in 4, maybe 1 in 3 patients are getting delirious. And that's what you want to try and avoid. Like ultimately, the end goal is to avoid this. So think of delirium as brain failure. The most common type is actually hypoactive, basically where the patient is a bit sleepy. They're not really awake when you go on to see them on the morning ward rounds. They're not really awake for most of the day, and then they wake up in the evening time and just start getting really agitated. They're not eating or drinking. They're not mobilizing. And you can see why all of this just segues into poorer outcomes. They're not mobilizing, they're not eating, they start losing weight. You can't get them up and get them home. And there are ways to look for it in terms of the single question in delirium and the 4AT, and I'll talk about that a wee bit more. And why we want to avoid it is because they do really badly. If you get delirium, you're going to do poorly. You're more likely to die, you're more likely to stay in hospital for longer, get complications, and less likely to actually end up going home. And that's massive. Like if you're coming in for an elective surgery, I think people need to be consented that if they get delirious, there is a chance that they may not get home. Again, if you do get delirious, you're more likely to then go on and be diagnosed with subsequent dementia. And that's really important because if we can prevent delirium, we can potentially prevent people sliding down into the dementia process as well. And it's important to recognise that you can prevent delirium. About a third of these cases can be prevented. So in summary, lots more people will be having surgery, older people will be having surgery. A lot of them will have an underlying cognitive impairment and they won't always know it. And if they go on to get a delirium, you're much more likely to have a poorer outcome. And really, where can you intervene? And I think Dr. MacDarby has talked really nicely about what you can do in the intraoperative period. And even just from the point of view of looking at the patient themselves, and think about what happens on a normal day in your hospital. Like, are patients' relatives allowed in to see them before and afterwards? Do they get their hearing aids? The amount of dentures that have gone missing on wards, it's just mad. But think, is this being set up for the patient? Where we can intervene, or as geriatricians what we'd like to be doing, is making sure that people have a pre-operative baseline cognitive assessment, if possible, and looking for risk factors for delirium. Because if you can identify someone who's high risk for delirium, you can consent them for it. It can be part of the shared decision-making process. And then you can look to try and reduce the risk of delirium post-operatively as well. Then we also get involved seeing them on the ward. And again, if they are delirious, trying to treat that, minimise it and move forward. In terms of your pre-operative assessment setup, who all is involved? Is it kind of doctors, nursing? Do you have occupational therapists who could be getting involved, social workers as well? But the two main points as clinicians that I think could be done in kind of a routine assessment clinic is asking people, have they noticed a change in their memory? Some of them won't, even if they do have a memory problem. And the formal word for that is anosognosia. That'll be my scientific word for the day. But ask them, have they noticed a change in their memory? And then ask them if they've ever had a previous delirium. Because if you've had a previous delirium, you're much more likely to get it again. And every subsequent delirium kind of brings additional risk. Have they had surgery before and they got delirious, or if they were ever delirious during a hospital admission? You could then go on to do a mini COG assessment. So again, I think we're not asking you to do a full cognitive assessment, but at least a mini COG is a type of screen for cognitive impairment. And you can pick up those people who might say they haven't noticed any change in their memory, but actually you get them to draw a clock and it looks like this, and you know that there is something amiss. It only takes about a minute or two. You get the person to remember 3 words. So you say 3 words, get them to repeat them back, say, look, I'm going to ask you those in a few minutes. Then get them to draw a clock and put the hands in at 11:10. And then you come back and you ask them to remember those 3 words. And it's scored out of 5. And if they're falling down on that, then you could actually flag that maybe for an occupational therapist to do a more formal assessment or refer them onwards. But if you pick up that they're scoring low, then you might think that there's an underlying cognitive impairment, and it'll kind of trigger a higher, put them in a higher risk category. You could then start looking for risk factors for post-op delirium. And these are all cumulative. Like, obviously, the more you have, the higher your risk. Age being one of the biggest risk factors, and a previous history of delirium as well. If you have an underlying cognitive impairment in the form of dementia or depression, the more comorbidities you have, especially Parkinson's. People with Parkinson's are really, really high risk of getting post-op delirium. Hearing and visual impairment as well, making sure they have their hearing aids or their glasses. Alcohol, polypharmacy, and again, it's the role of the pharmacist coming in terms of looking at their medications, and even just the type that, certain people accumulate medications as you get older, and there are certain ones that will make you more likely to have kind of issues with delirium. So looking at your cholinergic burden, everybody seems to be on amitriptyline these days. And again, like in an ideal world, you'd be seeing these patients weeks in advance of their surgery and trying to modify all of this. So are there medications that could be stopped? So, could we wean down the sleeping tablets? Could we wean down the thiazide that they're on? They've already got a little bit of a hyponatremia. They're maybe a bit dizzy or kind of unsteady on their feet. Trying to cut back as much as you can or optimize the rest of them. And obviously, if you're having a major surgery, you're more likely to get delirium. So you've seen them in your clinic. You've found that they have a cognitive impairment and that they have kind of a couple of risk factors for delirium. So what can you actually do? And I think the main thing here is you need to consent them that they're at risk for delirium and all that entails, and make that part of the shared decision-making process in terms of going forward with the surgery. And really ask them, if you got delirium or a post-operative cognitive decline, what would that mean for you? Like, is this person living at home with carers 3 times a day, family calling a couple of times a week, but there's nobody there overnight? They've had a few falls, but they didn't remember to use their pendant alarm. Like, if they get delirious, really they're on the cusp of maybe not making it home. Because if they need a bit of increased care, really that's, after the surgery, there is no room for increased care is going in there. And what would it mean? Like, ultimately it might mean they need to go to a nursing home, and is the risk worth it? And you really have to talk that through. And it's not to say that they shouldn't have surgery, and very much we'd want to optimise it. And if surgery is the right call, that's absolutely fine, but it just has to be part of the process. If you have identified that they have an underlying, say, a cognitive impairment, and they don't know about it, and no one else has picked up on it, and maybe the family are saying, actually, their memory hasn't been as good, refer them onwards to a geriatrician. It doesn't have to stop them going for surgery. They don't need to see the geriatrician before the surgery if they're not very high risk or anything, but certainly we would want to know, we would see those people and get them assessed. And really, I'm coming back to this point. The end goal is to try and prevent delirium and post-op cognitive decline, and about 1/3 of cases can be prevented. But it's not going to be any one single intervention. It's going to come down to these multi-component interventions and multidisciplinary input as well, from pre-op all the way through to post-op, and looking to identify the high-risk patients. And Dr. MacDarby's already talked about BIS monitoring, and even more complicated than I would have thought in the past. But all those, I suppose, principles of enhanced recovery are the same as the principles for delirium prevention. And it's about getting the patient, say, post-operative, getting them up, mobilising, eating and drinking, pain-free, taking out catheters, taking out cannulas, basically kind of less is more, and just trying to get them back to their normal selves as fast as possible. And then you'll see kind of all these other things. There's no real evidence to, for or against, but it's going to be little by little, all of this helps. Post-operatively on the wards is where we see the delirium, and what do you do if you suspect somebody has it? And really, at the minute, these are surgical interns managing it, and that model of care, I think, has to change. Most junior people in the hospital managing some of the most complicated patients. Writing that they're confused or have a GCS of 14 out of 15 isn't particularly helpful. It doesn't give you a huge amount of information. Are they delirious? So yes or no, do a screen for it. So the single question in delirium basically, is this person more confused than normal? That's it. And if they are, then they have a high chance of being delirious. I think the nurses are supposed to be doing daily 4 ATs on general medical wards, and I'll come to the pathway now in a few minutes, but just screen for it and write their score in. This should be part of the routine OBS. If you find a delirium, what is it that could be driving it? Is it infection? Is it pain? Are they constipated? Are they not sleeping? And just try and resolve it early and look for people to help you with this. Like often there will be dementia nurse specialists in the hospital, geriatricians. There's often people who will actually want to get involved in this to try and alleviate it and just resolve it early, and then document it. Again, there's a huge burden of morbidity associated with delirium. You're more likely to go on and get a dementia. If you've had a delirium secondary to a medication, that should be documented or even put on their Cardex. And we're really poor at documenting it. Even like medical teams are very poor at documenting it, and there's far more of it than you would realise, and it doesn't make it to the discharge summary or part of hype data. Just a note, and I know this is not even controversial, but just haloperidol is not a treatment for delirium. Delirium is a whole talk in itself, and treatments for it are a talk in itself, but it won't reduce the length that somebody has delirium. It won't reduce the actual delirium itself. It's really a last resort, and it's uncomfortable and has a whole load of problems. So we tend to avoid it if we can. These are the delirium pathways that most hospitals will have now. There's a national dementia pathway resource, and these are available. Anyone can see these. They're online, but they'll be in every hospital ward essentially as well. And they were designed there's ones for ED, AMAU, and this one is for general hospital wards. Now, I don't know if they looked at surgical wards, but it's fairly translatable to all wards. It looks a bit complicated, but basically identifying people who are at risk, and then what do you do? So the importance of screening for it in the 4AT and documenting it daily. So the nurses should be documenting that daily, or anybody should be documenting that daily. And then what to do if you actually find it. So looking at the pinch me, so pain, infection, constipation, hydration, medication, and the environment. And then talking to families as well and explaining that this person has a delirium. To conclude, there are time points where you can intervene, so pre, intra and post-op, and there's not going to be any one solution or a simple fix to this, and I think it's going to be systems based in terms of multi-component and multidisciplinary interventions. I think we need to work kind of across disciplines for this. If there's one take-home message you have from this talk, it would be to look for cognitive impairment. There is more of it than you think, and it has a higher impact than you would think as well, especially when we see them kind of post-op on the ward. Consider screening for delirium and looking for risk factors, and even documenting it, saying, we should be getting surgeons or anaesthetic notes to get the nurses to look for kind of post-operative delirium, and if it happens, then take these steps, and then looking at what happens to patients on the wards afterwards and getting ourselves involved. Same take-home messages. The risk of delirium can be modified, and we can prevent it. So thank you very much.
Okay. It just remains me to say thank you so much to our speakers. I'm afraid we don't have time for questions just now. So that concludes the session, and thanks very much.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Peri-operative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.